Upon entering the healthcare system, either by emergency medical services, emergency department, or direct admission from a clinic or community setting, a comprehensive history and physical examination is a primary evaluation. This aids in identifying the mechanism of injury, time of injury, and baseline deficits. Once it is determined that a head injury is suspected, clinical decision evaluation tools will be utilized to determine management of care as a secondary assessment. Examples of tools include, but aren't limited to, MGCS, Pecan, Petty Burn, Catch, Chalice, Health and Behavior Scale, Acute Concussion Evaluation, ACE, Post-Concussion Symptom Scale and/or Inventory, and Optic Nerve Sheath Diameter. The clinician and facilities protocols dictate the validated age-appropriate tools utilized, but the clinician can add to that selection based on the injury presented. Routine imaging is not normally indicated for diagnosing a mild TBI. The symptoms and the neurological deficits the child with a mild TBI presents to the healthcare provider with will determine if a CT scan or MRI is indicated. Imaging identifies an intracranial injury with a suspected TBI, and the symptoms, clinical decision tools, and abnormalities detected determines the course of management. Once a clinical decision tool is utilized, frequent follow-up with tools is required to determine if subtle changes occur and if interventions are effective. Once validated assessment tools and a comprehensive history and physical are performed, treatment is prioritized to prevent further injury. These actions all occur concurrently. Intravenous fluid provides fluid and electrolyte replacement and allows access to medicate the child. Respiratory support is initiated if required. Serial neurovascular checks are initiated to obtain a baseline and note changes. If bleeding is occurring, measures to cease hemorrhage and contain the wound are initiated. A fundoscopic exam is performed to check for papilledema, which is present with increased intracranial pressure, and retinal hemorrhage, which may indicate abuse. The physical exam includes palpating of the head and crepitus in bones and joints. It will also reveal any protruding anterior fontanelles that wound indicate increased intracranial pressure. Auscultation for brute sounds in the neck will reveal any dissections of major arteries. Musculoskeletal assessment will reveal any loss of bladder or bowel control, extremity weakness, tenderness, paresthesia, or priapism, signs of spinal cord injury. Signs of non-accidental and potentially abusive trauma include retinal hemorrhage, significant neurologic injury with minimal signs of external trauma, multiple injuries in various stages of healing, and bilateral chronic subdural hematomas in young children. When the child is initially presented for healthcare, a preliminary assessment will prioritize care based on airway, breathing, circulation, and addressing the findings of the history, physical, and clinical decision tools.